We will be discussing about the medial side of the knee. So what is the medial side of the knee? What are the ligaments on the medial side of the knee? So medial side of the knee is pivot of the knee. So basically it forms a very important ligament, and as compared to any other ligament, so if you compare about ACL, PCL, MCL and LCL, the medial sided ligament of MCL ligaments are the most flat and wide ligaments which are there. So if you see ACL, it's a round ligament, sort of an oval ligament. PCL also is a broad sort of a round ligament. If you see LCL, it's also a rod-like structure. As compared to them, the MCL or the middle side is a flat ligament. It is composed of three main structures. Number one is superficial MCL, which is the most important structure. Then you have a deep MCL, and then you have a posterior oblique ligament, POL, posterior oblique ligament. So these three ligaments make a sort of flat layer on the medial aspect of the knee. They basically arise from the medial condyle and medial epicondyle region, and it fans out to attach on the medial side and on the posterior side of the tibia. So what that means is it's a structure which gives medial support to the knee. Now these ligaments can be injured with trauma, so they can be associated with an ACL tear or a PCL tear. So whenever there is an injury to ACL, PCL complex, you also should rule out injury to the MCL. And I will personally consider an MCL injury significant if you have a more than 5 millimeters medial opening. And you have to check the opening both in extension and mid-flexion. So that is important. So important things, as I told you, if you talk about MCL, MCL is more into flexion, and if you talk about the posterior oblique ligament, it is more into extension. So the POL will support into full extension. Whenever you tighten the posterior oblique ligament, you have to tighten in about full extension. And if you want to tighten the medial collateral ligament, typically the superficial MCL part, you need to tighten it in the flexion degree. So approximately 60 degrees, 30 to 60 degree of flexion is the right degrees where you want to flex. Now primary injuries of MCL can be on the femoral side, in the mid substance, or in the tibia. So the treatment varies. If you have a medial sided injuries, you need to repair on the femoral sided injuries, you need to repair it with suture anchors on the femur. Also, they are good prognosis injuries. So if there is a medial sided injury on the femur up to grade 2, you can give a conservative trial because these injuries may heal. The second type of injury is a injury of the mid substance. So these injuries should be repaired with direct end-to-end repairs. And then you have an injury on the tibial side. But tibial side injuries are notorious, they don't heal well. So if there is an injury to the tibial side, ideally they should be repaired. But the important thing is that the tibial insertion of the MCL, superficial MCL, is about 6 to 7 centimeters below the joint line, and it's just beneath the pes. So whenever you will expose your ligaments for the ACL, you will find the MCL attachment right there. So if there is a tibial sided MCL avulsion, whenever you will take the graft, you will see that just underneath it, the MCL is torn and you might need to repair it. Now this is a cortical bone, so ideally you need to have something which is anchor, which is fixed with a cortical bone. So at present my preference will be all suture anchor to fix this particular defect. So all suture anchor on the tibia or a regular anchor, but the problem is that it is a cortical bone. So in your cancellous bone, the peak anchors and the metal anchors holds well because they are based on the cortico-cancellous fixation. Here it is predominantly a cortical bone. So at present, I would recommend something sort of an all suture anchor to repair these kind of tibial avulsions. Usually, I would recommend a primary repair as far as possible up to about a month of injury. Rarely, if the repair is not possible within a month of injury, then you might have to do a reconstruction surgery. And there are many techniques of reconstruction surgery which are described, but the Lapradie technique is more popular, and that technique basically is a two-limb reconstruction. So it focuses on reconstruction of both the MCL and the posterior oblique ligament. So what it does is you take two ligaments, two tendons, fix one on the femur and tibia as a superficial MCL, and fix one as a posterior oblique ligament. So that you take on the femur and on the posterior part. So posterior oblique ligament attaches on the posterior part of the tibia, posterior middle part of the tibia. So one ligament is there, and you have to tighten that graft in about full extension. And the superficial MCL part graft, you need to tie it in about 60 degrees of flexion. Also, you can recreate the deep MCL by fixing the superficial MCL graft with an anchor at the level of joint line. So it will recreate the deep MCL portion. So you use two interference screws, one on the femur at the insertion at the origin, and one on the tibia at the level of superficial MCL, and then one anchor fixation just below the joint line. So that will recreate the deep MCL. So that is called as this is called as a Lapraday's two bundles or two graft reconstruction of the medial side of the knee, the MCL, which includes superficial and deep MCL, and parts of the posterior oblique ligament. So that is one very common scenario which you will face in your clinical practice is a patient who is undergoing a knee replacement surgery, and during the knee replacement surgery or following the knee replacement surgery, the patient has a MCL tear. So this is a very common scenario you face, because in most of the ligaments, joint replacement surgeries, you are not dependent on ACL and PCL. They are anyway cut. So if you are doing a PCL substituting knee, you will remove the ACL and PCL, and then the whole balancing of the knee will depend on the medial collateral. Now here, in case of a total knee replacement, the most important part is the superficial MCL. So when you are doing a total knee replacement, you can release the deep MCL completely. You can release the posterior oblique ligament. So you can do a circumferential release near the joint line of the medial side of the knee safely without any problem. But you cannot erase the distal portion of the MCL. So if you erase the distal portion of the MCL during a total knee arthroplasty, that is a disaster, because then it calls for a instability and it will be total opening up of the joint of the medial aspect. So that is very important. So whatever you do, you erase on the medial side, totally on the medial and the posterior medial aspect, but never release distal. That is very important. Super deep or the distal superficial MCL release should not be performed, because that will lead to a drastic opening of the medial side, and then it is a disaster. Because if these patients come to you late with a late MCL and medial sided opening, they are unstable and nothing else except a knee joint can help. Okay. So supposedly, if you identify this complication during your surgery while doing a total knee replacement, then you need to fix it up at that time. So if you by chance erase the distal MCL by mistake, then you put an anchor and repair it then and there. Don't leave it, don't accept it. The second common error is usually the saw blade which cuts the substance of the MCL. That also can occur. So in that scenario also, you need to reconstruct, you need to repair the MCL, and occasionally you should be ready with your graft. So supposedly it is cut, you can reconstruct at the same time. Intraoperatively, you can reconstruct the MCL. So that is one thing that you should know. So that is why the MCL reconstruction techniques you should know also while doing a total knee replacement. And the third thing is, occasionally the MCL is very tight and you are releasing and you are not able to regain the MCL length. Then what is the best technique? What will you do? You are releasing the medial joint, you release the deep MCL, you release the posterior oblique ligament, the posterior part of the capsule, still the medial side is tight. What will you do? What is the best approach in those techniques? Some people recommend a pie testing of the MCL. Still, if you are not able to, then also never erase from the distal tibial side. Distal MCL, distal superficial MCL, you should never release. What you need, what can you do at that point of time? So femoral osteotomy. So you do a distal medial femoral condylar epicondylar osteotomy. So you just use your osteotome to break it as with a bone, along with a bone, and then you can just leave it, or you can fix it with a screw, and that will give you the desired opening. So never erase the distal tibial part. That is the message. So either you do a sliding osteotomy of the medial epicondyle, that you can leave as it is, because that will heal because it's a stable sort of osteotomy, or occasionally you can put a screw to fix that.
What is the size of the femoral bone?
You usually can take about 2 to 3 centimeters.
You can fix with upright cancellous.
Or you can just leave it also. You can just made a osteotomy, then you just do your balancing. It's a stable sort of osteotomy. It will just slide a little, and it will be stable there. So that is one thing that you can do, but never release the distal MCL. This is a disaster. So even if it happens, similar scenario you can also face while you are doing a HTO. Because in HTO also you need to put the plate on the medial aspect of the knee, and you need to erase the superficial MCL and the MCL to put that plate. So again, don't erase the distal most part of the MCL. You can erase the medial part, you can erase the deep MCL, but never erase the superficial MCL. It will become lax. It is very especially important in HTO, because if the patient has a valgus and he has a MCL deficiency, it will not be tolerated. If the patient's knee is in varus and he has a MCL deficiency, it will still be acceptable. So in an HTO patient, if you have a MCL deficiency, again it is a disaster, because the patient's leg will be in valgus and the MCL will open away. So the patient will develop a significant instability of the knee. So again in HTO you need to be very cautious about your MCL, and specifically the distal insertion of the MCL. Okay? Any questions?
Sir, can we use some, you said that in distal part of the tibia, we can use all anchors for that.
Also, yes.
Any plastic material you can use on that anchor?
Peak anchors? You can use, but the problem with using peak anchors is they are basically meant for cancellous fixation. So peak anchors are very good for using greater tuberosity in your hip joint, all portions where you have a cancellous bone. So they don't have a very good fixation in cortical bone. So what happens is, because they rely on the threads, and threads can fix well in a cortico-cancellous sort of bone. This is a pure cortical bone. So for them, the screw-in anchors is, you can use it, still you can use it, but I will not say it is an optimum fixation.
That screw with that one.
You can use a screw with a washer.
Washer, yes.
That you can use, yes. Spike washer. That is usually used on the femur. But tibia, ideally I would recommend anchors, whatever you want, whatever anchor you have. Anchor fixation is best for tibial sided superficial. All suture is the number one choice, but you can use any other anchors as a second choice. But anchor fixation is, I think, should be the best option. There is low profile also. You can use it in double row fashion. You can make it a double row. You can prepare the first one, then you can prepare. The important thing about the MCL is a very flat ligament. So as compared to the other ligaments, it's like a chapta ligament, flat ligament. So that you need to take care, and it's very flimsy. So when there is a tear, you have a very thin layer, sort of a thin, broad layer of the ligament which needs to be repaired.
You have to take care of when you put the postomedial plate also, I think, in that.
Postomedial is safe, because if you are putting postomedial, then you are sparing the medial side of the knee. That is safe. So anything which is affecting the distal MCL, then you have to take care. Posteromedial plate is relatively safe. You will not erase it. And the other technique is some people do an extra periosteal plate. So you put the plate over superficial MCL. That is okay. So some people also do osteotomy beneath the MCL for HTO, and then put the plate over the MCL. So that you can do.
If you put the plate over, it doesn't die it open.
It doesn't damage it.
Okay.
So you can just do your osteotomy at the level of the at the level you desire, and then you do an osteotomy, elevate it, and then fixation wise plate you put an extra periosteal plate. So you put it above the MCL. So that is one option that you can do. That is safer. But if you want to put a plate on the flush on the bone, then you have to erase the MCL part, and that is risky. So if you have to do that, do it with due care, preserving the distal attachment of the MCL. That is a key. Thank you.
Thank you.